Okay, so this brings us to the last talk, the last board simulation session. And this is not going to take the whole hour, maybe 40 minutes, 45 minutes. We're going to go quickly. These are just going to be review questions. A lot of this you've already heard during the week, but I want you leaving here confident in getting most of these questions right. But there will be some things that we haven't touched on that are important. So let's just roll. So a previously healthy 13-year-old boy develops fatigue, low-grade fever for 2 weeks, and painful nodular lesions on his lower extremities. Okay? I think you've probably seen these pictures before. What's the most likely diagnosis in this 13-year-old? Rheumatic fever, Pseudomonas infection, IBD, Lyme disease, or parvovirus? Okay, very good. So inflammatory bowel disease, 13-year-old. Remember what Dr. Mahajan told you, that they're going to present to you a 13, 14, 15-year-old with IBD, and erythema nodosum is strongly associated with IBD. These are painful, indurated lesions, usually on the shins, often symmetrical. They can be in the upper extremities as well. And this is the differential diagnosis of erythema nodosum. Strep infection is probably the most common. Certainly the fungal infections that we talked about earlier today. You always want to think about TB, but again, they're going to have to give you some epidemiology there to point you towards TB. Some of the rheumatic causes, IBD is a big one, okay? All right, so a 5-month-old baby presents with a 1-day history of high fever and irritability. On physical exam, he appears ill and has an indurated erythematous area on his left cheek, which is not fluctuant. And I want you to tell me the most appropriate therapy for this baby, and I'll show you a couple of pictures. This is 1, and this is 2. I want you to focus on this area of erythema here, as well as here. It's indurated, and I tell you the baby has high fever and is irritable, and it's only a 5-month-old. So what do you think we need to do? Topical mupirocin, an oral anti-staphylococcal therapy, surgical drainage, systemic IV antibiotics, or just observation? Okay, very good. So this is what? What's this called? Buccal cellulitis, okay, which we don't see much today given Hib vaccine. This used to be very common prior to Hib vaccine, but we still occasionally see it. These kids are usually bacteremic. The mean age is 11 months, so early in life. Concomitant meningitis, especially in young infants, and about a third have a concomitant ipsilateral otitis. Before Hib was by far the most common cause. Now the most common cause is probably pneumococcus, okay? All right, 14-year-old girl undergoing chemotherapy for AML presents with fever, neutropenia, and this skin lesion, which again, you've seen a couple times this week. So what's the most likely agent causing this condition? Everybody should get this right. Is it Listeria, Staph, Strep pyogenes, Pseudomonas, or Candida? This is a neutropenic, leukemic patient. Close to 100%. Okay, so this is ECTHYMA gangrenosum. Okay, it's a necrotic ulcer. There's usually a black or a gray eschar. This is, again, signs of Pseudomonas sepsis in an immunocompromised. It's almost always going to be a neutropenic patient, usually a leukemic. It can be caused by other gram-negatives as well as Aspergillus, Candida, and Staph aureus. You can usually isolate the organism from both the blood as well as the lesion. This boy presents with a rash and arthritis of the lower extremities. What's the most likely additional feature that this child is going to have? And I'll show you a couple of photos. Okay, so rash, arthritis, and what else? IgG-mediated renal involvement, thrombocytopenia, abdominal pain, seizures, or facial edema. Okay, I got to go back and look. Yes, this is HENOCH-SCHONLEIN purpura. So purpuric lesions and arthritis are the most common manifestations, but GI symptoms are going to be present in about half the kids, usually abdominal pain, bloody stools, intussusception, and corticosteroids. I don't think they're going to ask you about the indications for corticosteroids. We usually use them for GI symptoms with HSP, and maybe for arthritis. They may be of some benefit there. Steroids do not help with the renal involvement. Remember, this is IgA deposition. This is like IgA nephropathy with the rash, and CNS complications are rare. All right, an 8-month-old presents with a 24-hour history of high fever and irritability. He's toxic and has a bulging anterior fontanelle. And you see his spinal fluid there, 2,100 white cells, mostly polys, protein of 200 and a glucose of 10. And here's the gram stain. What's the most appropriate initial antimicrobial regimen for this child? Vancomycin, ceftriaxone, AMP and ceftriaxone, AMP, or vancomycin and ceftriaxone. Okay, very good. So this is bacterial meningitis. We think this is what organism from the gram stain? Looks like these look like gram-negative diplococci, right? So it could be meningococcus, but you never want to totally rely on a gram stain, especially with bacterial meningitis, so I guess it could be pneumococcus as well. So empiric treatment until you have a culture in your hand is going to be vanco and ceftriaxone, okay? Previously healthy 16-month-old with high fever for 5 days associated with irritability. The exam is non-focal except for a pinpoint red rash on the trunk. 3 weeks prior to the onset of fever, he was traveling with his family to India, and the blood culture grows a gram-negative bacillus. What's the most likely diagnosis? Shigella, Ehrlichiosis, Salmonella, Typhi, Kingella kingi, or Pseudomonas? Again, if you were paying attention earlier today, this should be clear-cut, plus the travel history should also give it away. Okay, so this is a very good presentation for typhoid fever or enteric fever in a returning traveler. The positive blood culture, the rose spots is the pinpoint red rash on the trunk. 2-year-old boy develops pallor and a purpuric rash, and his blood count shows a hemoglobin of 6, white count of 1,200, and a platelet count of 20,000. Kind of bad news. So what's the agent most closely associated with this diagnosis? Chloramphenicol, nafcillin, vancomycin, ceftaz, or clindamycin? All right, very good. This is aplastic anemia. Although we don't use chloramphenicol very much, it still shows up on board exams, and they mainly want you to know that it can cause aplastic anemia. 8-week-old presents with a 2-day history of dry cough and nasal congestion. He's well-appearing, afebrile, and a respiratory rate of 50. He has mild subcostal retractions, rhonchi and rales, and a chest x-ray shows some hyperinflation and diffuse interstitial markings. 8-week-old. So what's the least likely to cause this clinical picture? Is it RSV, group B strep, CMV, chlamydia trachomatis, or ureaplasma? Even if you didn't know very much about some of these bugs, you should be able to pick out the one that just doesn't fit. Okay. And you didn't. So is this a good story for Group B strep? So no. So this would be late onset Group B strep. And how do babies with late onset Group B strep present? They almost never present with pneumonia. They present with high fever, bacteremia, and meningitis, okay? So even if you didn't know anything about ureaplasma or CMV, all of those are common causes of what we call the afebrile pneumonia syndrome, which is common between 4 and 12 weeks of age. They're generally well-appearing babies. They have mild respiratory symptoms, a lot of coughing, rales, and their chest x-ray is nonspecific. The most common cause of this is chlamydia trachomatis, and most commonly they will tell you that the baby had some conjunctivitis, you know, a couple of weeks earlier. But all these other agents have also been implicated and can cause this, including ureaplasma, perinatally acquired CMV, not congenitally acquired. Pneumocystis has also been implicated as causing this in normal, healthy babies, okay? Self-limited, you usually don't need to treat this unless you know it's chlamydia, in which case we would treat them with erythromycin. Bless you. A 3-day-old infant who was born at home develops copious purulent drainage from both eyes. I'll show you the gram stain from the drainage. The baby's admitted and undergoes eval for disseminated infection. What's the most appropriate empiric agent for treatment of this infection? Topical erythromycin, oral erythromycin, IV penicillin, or IV cefotax. This copious purulent drainage from the eye. And this is a neonate, 3-day-old, who was born at home. That's a clue. So the baby didn't get something, right, in the hospital. So how do we treat these babies? Okay, so intravenous cefotaxime. This is Ophthalmia neonatorum. Oh, sorry, I forgot to show you the gram stain. Sorry, these are gram-negative intracellular diplococci. So this is Ophthalmia neonatorum, which is defined as conjunctivitis in the first month of life, which we just heard. The incidence directly related to prevalence of STD. The pathogenesis usually occurs prior to delivery via premature rupture of membranes. At delivery, usually contact with maternal genital secretions, and then they can also acquire this after delivery through direct contact or aerosolization. So these are the most common causes of Ophthalmia neonatorum. Chlamydia trachomatis is the most common cause, 2 to 40%, and usually presents 5 to 14 days of age. GC, which is very rare today because the prophylaxis that we use prevents this. So it's very rare, but those babies, if they don't get prophylaxis, present between 2 and 5 days of life. Other bacterial agents, their role is really not totally clear-cut. Always think about herpes simplex, and a chemical conjunctivitis is rare now because it used to be associated with silver nitrate, which we rarely use today. So for GC, again, is rare because of ocular prophylaxis, presents in the first week. There's severe eyelid edema and purulent conjunctivitis, and they can get scarring without appropriate treatment. Ulceration, scarring, perforation, endophthalmitis. And you also have to think about extraocular GC infection as well. The diagnosis we usually make with a gram stain. Whenever you see intracellular gram-negative diplococci, that's the diagnosis you can confirm by culture. You want to test mom. You also want to test for syphilis, HIV, and concurrent chlamydia. And you want to get blood and CSF culture. You want to hospitalize all these babies. We treat them with IV or IM ceftriaxone. Sometimes we don't like to use ceftriaxone in neonates because of hyperbilirubinemia. In this case, we use cefotaxime. A single dose of ceftriaxone is usually effective. but we usually treat until we actually have negative blood cultures, negative meningitis, etc. Eye irrigations and saline solutions are used hourly and then every 2 to 3 hours until the drainage resolves, and you don't need to use topical antibiotics. Chlamydia trachomatis, again, is the most common infectious agent, and the likelihood that an infected mom will transmit this to the baby varies anywhere from 18 to 60%. These babies present a little later, 5 to 14 days of age, with eyelid swelling, erythema, and a mucopurulent conjunctivitis. It can be unilateral or bilateral, and if these babies are treated, they usually do very well. Remember that these babies can actually harbor the organism in their nasopharynx, so they can get pneumonia. Usually presents again 1 to 3 months later, and it's the most common cause of the afebrile pneumonia syndrome that we just talked about. You make the diagnosis usually through tissue culture. The nuclear tests are more sensitive and rapid, but they are not FDA approved for a conjunctival swab. And the treatment is erythromycin orally for 14 days or azithromycin for 3 days. The efficacy is approximately 80% for both of these. Remember, there is a risk with macrolides of idiopathic hypertrophic pyloric stenosis. We think it is less common with azithromycin than erythromycin, but it has been associated with both of those. Topical therapy, so if you try to treat conjunctivitis with topical therapy, you will not eradicate nasopharyngeal colonization. So that's why it's recommended that we treat these babies systemically with either erythromycin or azithromycin. And prophylaxis of babies born to infected moms. So if you know that a mom has a positive chlamydia, we don't recommend treating the baby unless the baby develops conjunctivitis, because the effectiveness of treating the baby empirically hasn't been proven, and again, because of the risk of idiopathic hypertrophic pyloric stenosis. Okay, which of the following is true regarding the acute complications of RSV? Serious bacterial infection rarely complicates this. Apnea is a rare complication. Lower respiratory tract disease and respiratory failure are more common with reinfection than with primary infection, or immunocompromised children are at low risk for severe RSV disease. Okay. Yeah, the right answer is A. A lot of you picked C. Lower respiratory tract disease is much more common with primary infection than with reinfection. So the first time a baby sees this, they are much more likely to have pneumonia and bronchiolitis than with subsequent exposures. Serious bacterial infection rarely complicates RSV disease. That is true. Apnea, as you know, is a common complication. Primary infection more severe. And these are the high-risk groups for severe infections. So preterm babies and children with chronic lung disease, hemodynamically significant heart disease, especially cyanotic heart disease, and immunocompromised patients are at very high risk for severe infection, and these are the groups that we would consider prophylaxing with palivizumab. 5-year-old sickler develops osteomyelitis. What's the most likely organism? Strep pneumonia, Staph aureus, Bacteroides, Salmonella, or group A strep? This one's a little tricky, but not really. Okay, very good. So Salmonella is the right answer. For many, many years, we thought that the right answer was still Staph aureus, just playing the odds, but actually somebody went back and looked at this and published this paper many years ago where it was definitively shown that Salmonella is more common than Staph aureus. If they ask you this, just pick Salmonella. Previously healthy 2-year-old girl presents with acute history of high fever, chills, vomiting, and diarrhea. She's pale, icteric, listless, febrile, and tachycardic, and has hepatosplenomegaly. The white count is listed there. Her hemoglobin is 7.5 and platelet count of 90,000. In the ED, she becomes confused and has a 5-minute tonic-clonic seizure, after which she becomes obtunded. 1 week prior to her presentation, she was with her family visiting relatives in sub-Saharan Africa. What's the most likely cause? TB, Plasmodium falciparum, Plasmodium vivax, West Nile, or yellow fever. So really, really a sick kid. Okay, very good. So this is falciparum malaria. These are the areas of the world that are at greatest risk, intermediate risk, and low risk. You're all familiar with the manifestations. The fevers may be cyclic, appearing every 2 or 3 days. Anemia, thrombocytopenia from hemolysis and hypersplenism are very common. And falciparum is the bad one. This is the one that's potentially fatal. Young children, though, will present with just a febrile, nonspecific flu-like illness. This is the one that's associated with high degree of parasitemia. This bug is usually chloroquine resistant, and the one that causes cerebral malaria. And these are some of the other complications that you can see here, which are very severe. Plasmodium vivax and ovale usually are more subacute in nature, and they present with anemia, hypersplenism. These are the two, though, that can relapse because there's a hepatic stage that you also need to treat. So if you don't treat this hepatic stage, it can relapse many, many years later. The way that we identify these parasites is by doing thick and thin blood smears. The thick smears are to find the parasites, and the thin smears are to identify the species and the degree of parasitemia. And you should just remember that for severe malaria is generally defined having greater than 5% parasitemia, and those kids need to be in an ICU and receive parenteral therapy, usually with quinidine. And we recently had a couple of kids at the clinic with malaria that we had to do that. So a 10-year-old boy with sickle cell is admitted to the hospital with fever to 39.5, respiratory rate of 50, costal retractions, and a chest x-ray that shows a left lower lobe pneumonia. What's the least likely agent to cause this infection in this boy? Here's the pneumonia. See right here. So which is least likely in a patient with sickle cell? Pseudomonas, pneumococcus, Hib, Salmonella, or Mycoplasma? This one's a little tricky too, I think. Okay. Yeah, the right answer is A. So remember, sicklers have a very difficult time with encapsulated organisms. So you got to pick out the ones that are encapsulated. So strep pneumo, Hib, and Salmonella, those are all encapsulated. Those are all common infections in sicklers. So that leaves you with Pseudomonas and Mycoplasma, and you just have to know Pseudomonas is not a common bug in sicklers at all, whereas Mycoplasma pneumonia, sicklers have a very, very difficult time with it, and it is one of the proposed causes of chest crisis, acute chest crisis. So the right answer here would be Pseudomonas. Another question about Lyme disease, which is true? Carditis and aseptic meningitis are features of late disease. Arthritis is a common early feature. Amox is the treatment for children less than 8 years of age with early localized disease. Repeated courses of antimicrobial therapy are often required, or despite antimicrobial therapy, chronic Lyme disease is common, which is true. Again, even if you didn't know very much, if you just knew one fact about it and you know that it's true, you just got to mark it and move on. All right, good. So most of you figured that AMOX is the treatment for children less than 8. These are the early localized disease manifestations. Erythema migrans is the biggie here. And then early disseminated disease is when we see multiple erythema migrans rings. Cranial neuritis, meningitis, and carditis are all features of early disseminated disease. And then arthritis is usually weeks to months after the initial illness. That is late disease manifestation. And just some more pictures of erythema migrans. And this is the treatment which we went over this morning. Doxy for 8 years and older, AMOX for less. Bless you. All right, 2-year-old presents to the ED, 3-day history of bloody diarrhea, pallor, and lethargy. Several of the child's daycare center mates have diarrhea. One has been hospitalized with dehydration, anemia, and renal failure. So you suspect HUS, which is a true statement about HUS. The prognosis is excellent in most cases. The diagnosis of HUS is made by obtaining appropriate stool cultures. Antibiotics effective against E. coli 015787 should be used to eradicate the organism, or CNS manifestations occur in 40%. Okay, very good. So the answer is the prognosis is excellent. B is not correct because the diagnosis of HUS is a clinical diagnosis, and many times the stool cultures are negative because HUS develops after the bloody diarrhea. We don't like to use antibiotics because they may make things worse, and at best don't do anything to help. And CNS manifestations are much rarer, maybe about 10% of cases. Okay. I went through all of this. Meticulous medical management, supportive care, dialysis, no antibiotics, and most children do well. All right, we don't need to do audience response here. These are agents of bioterrorism, which they will expect you to recognize the major clinical features of these, and these have been popping up more and more. So let's just talk about which of these cause respiratory distress followed by shock and a widened mediastinum on chest x-ray. You guys remember? All right, that is anthrax, inhalation anthrax. Which one causes flaccid paralysis? All right, that one's pretty straightforward. That's botulism, right? Which one causes painful regional lymphadenopathy and pneumonitis? This can be a couple of them, but the most likely one is Yersinia pestis, bubonic plague, and pneumonic plague. Which one causes a vesicular rash? All right, that one is smallpox. And this one from this morning, papular lesion and cervical lymphadenopathy. That's tularemia. And painless ulceration and a black eschar. That's cutaneous anthrax. Okay, so if you just know those little facts about these, you'll be fine. All right, we're going to do a non-infectious disease question here, which is a true statement regarding infants of diabetic mothers. Most of these babies are SGA. The neonatal mortality rate is similar to that of infants of non-diabetic mothers. They have increased risk of congenital anomalies, or symptomatic hypoglycemia occurs in the majority of these babies. Okay, very good. So C, these babies are certainly at risk for any of these congenital anomalies, which I have listed here. They tend to love it, as I think Dr. Mahajan told you, they love the small left colon syndrome, and a lot of times they will actually show you a picture of this, which is here. So infants of diabetic mothers strongly associated with small left colon syndrome. All right, a couple of more here. A 6-year-old girl with nephrotic syndrome presents with abdominal pain and fever. She takes 30 milligrams of prednisone a day, no diarrhea or vomiting. Her abdominal pain has worsened and now is severe. She's febrile, tachycardic. The blood pressure is borderline. She's ill-appearing. Her abdomen is distended with guarding and rigidity, and her bowel sounds are absent. The white count is 14,000. What's the most likely diagnosis? Acute appendicitis, bacterial gastroenteritis, spontaneous peritonitis, bacterial pneumonia, or intussusception. And Dr. Cunningham's going to be very upset if you don't all get this right. Okay, very good, 90%. So this is primary peritonitis or spontaneous peritonitis. Now the other question about this, so you do a paracentesis, which confirms the presence of spontaneous bacterial peritonitis. But what's the most appropriate antibiotic regimen for this patient? Ampicillin, Gent and Flagyl, Nafcillin, cefotaxime, or clindamycin? This one is tricky. Think about this. This is spontaneous bacterial peritonitis. You got to think about the bugs and what you need to cover empirically. Every year this one trips people up. And once again, it tripped you up also. All right, so what are the bugs that cause primary peritonitis? Strep pneumonia and E. coli. So if you chose Gent and metronidazole, you're not covering probably the most common cause, which is strep pneumonia. Okay, you don't need to cover anaerobes. This is not perforated bowel. This is primary spontaneous peritonitis. Okay, this is from bacteremia. So you need to cover pneumococcus and E. coli. So the right answer is D, cefotaxime. Okay, you do not need to cover anaerobes in this illness. This is extremely rare in healthy children. If they're going to give you this, it's always going to be as a child with nephrotic syndrome or a child with liver disease, cirrhosis, maybe collagen vascular disorder, but usually not. The source is hematogenous. And again, strep pneumonia and E. coli are the two biggies. Anaerobes are not common. It's important to distinguish this from secondary or perforated bowel, in which case anaerobes and gram-negatives. So Gent and Flagyl would be very appropriate for a kid with a perforated bowel. So you can use something like ampicillin and gentamicin, but we prefer to use a third or a fourth generation cephalosporin. All right, let's just shout these out. So they love to actually ask about the anti-tuberculous medications and their side effects. So you need to know these. So let's match rifampin with the choices on the right. So optic neuritis, interstitial nephritis, peripheral neuritis, hyperuricemia, biliary sludging, or staining of contact lenses. Which one is most associated with rifampin? Okay, F, staining of contact lenses. It can also cause hepatitis, especially when used together with isoniazid. What about isoniazid? All right, peripheral neuritis, okay, which is rare in children, and this is related to what vitamin deficiency? B6 or pyridoxine. So children who are being treated with isoniazid generally do not need to be supplemented, but a lot of times adults do because of B6 deficiency. What about pyrazinamide? That one's a little tougher because we don't use that commonly. D, that's hyperuricemia. Okay, very good. Ethambutol, this is an important one, ethambutol. All right, optic neuritis, okay, very important. Methicillin, or I could substitute oxacillin or nafcillin, or really any of the cillins. Yeah, that one's interstitial nephritis, okay? And finally, ceftriaxone, that one's easy. You're all familiar that it causes biliary sludging, which is not usually of clinical significance. All right, just a couple of more questions and we're done here. So a 14-year-old presents to the ED after being struck by a car while riding his bike. He was not wearing a helmet at the time of the impact. He's got a bloody discharge from his right middle ear and an area of ecchymosis in the right postauricular area. What's the most likely diagnosis? Basilar skull fracture, subarachnoid bleed, epidural hematoma, or a concussion? Okay, very good. The hemotympanum, ecchymosis of the mastoid area, which is a battle sign, raccoon eyes, these are all features of a basilar skull fracture. Know how to distinguish epidural hematomas from subarachnoid hemorrhage clinically. And the same patient does well except for persistent clear otorrhea. And several days later, he develops a stiff neck, headache, and fever. And his lumbar puncture shows 1,200 white cells, mainly polys, a high protein, and a low glucose. So in this setting, what's the most common bacterial cause of his meningitis? Staph aureus, Neisseria meningitidis, strep pneumonia, Eikenella, or Moraxella? So this is bacterial meningitis following head trauma. Oh. All right, so remember this morning we actually talked following head trauma, you get infected with what you're colonized with, and strep pneumonia is what you're most likely to be colonized with. So strep pneumonia is most common following head trauma. Okay, this is a well-known complication. CSF complicates basilar skull fractures. And again, strep pneumo and non-typable H flu also can cause meningitis in this setting. It's very rarely Staph aureus. 3-year-old boy has a heart transplant recipient being treated with ganciclovir for CMV pneumonia. We just want to know what the most likely adverse effect of ganciclovir. Is it anemia, thrombocytopenia, neutropenia, renal dysfunction, or rash? And adverse effects of drugs are all over the boards because they're non-controversial, they're easy to ask questions about, so they like to hit these hard. Okay, very good. Neutropenia, it can cause anemia and thrombocytopenia, but not nearly as much as neutropenia. And renal dysfunction really is not a major side effect of ganciclovir. 7-year-old has a history of congenital hydrocephalus and a VP shunt, presents with lethargy, headaches, and a low-grade fever. The shunt was revised 3 weeks prior to his presentation, and now he has cloudy fluid from the shunt. You suspect that it's infected. He's got a VP shunt infection. So in this setting, what's the most likely bug? Strep pneumonia, Neisseria, meningitidis, E. coli, coag-negative staph, or Pseudomonas? So a VP shunt infection. Okay, very good. So coag-negative staph complicates any foreign material, intravascular catheter, and VP shunt. So if you're just playing the odds, that is the most likely organism. You also certainly can have Staph aureus in this situation, the Propionibacterium acnes, Bacillus, occasionally gram-negatives as well, enterics as well as Pseudomonas, but those are not nearly as common as coag-negative staph. 1-day-old term baby develops bilious vomiting. Here's the X-ray. This infant's condition is most closely associated with CF, Turner syndrome, trisomy 21, DeGeorge, or vertebral anomalies. And you've heard this several times this week. right, very good. So this is trisomy. This is what? This is duodenal atresia, the double bubble, which is associated with Down syndrome. It's also associated with malrotation and esophageal atresia. All right, last case. I think we have 2 questions in this and we're done. Previously healthy 3-month-old presents with a 1-week history of constipation, poor feeding, loss of facial expression, and decreased movement of the extremities. You have an alert, afebrile infant who has a feeble cry, little spontaneous movement, poor tone, ptosis, reduced extraocular movements, and decreased deep tendon reflexes. What's the most likely diagnosis? Sepsis, infant botulism, viral encephalitis, transverse myelitis, or Guillain-Barré? So this is a classic presentation of, all right, infant botulism, okay? And what's the most appropriate plan of management for this infant? IV penicillin, IV solumedrol, botulism immune globulin, IV gentamicin, or plasmapheresis? All right, supportive care is most important, but we also try to treat these babies with botulism immune globulin. Remember that with infant botulism, they actually ingest the spores, which then germinate in the baby's intestine. Constipation is a huge clue here, okay? So history of constipation, acute weakness, difficulty sucking, swallowing, crying, and breathing. Sepsis is the most common differential diagnosis, and we try to isolate the toxin or the organism in both the blood as well as the stool. You don't want to give these babies antibiotics, especially aminoglycosides, because they may exacerbate the neurologic effects. And just remember, Guillain-Barré causes a polyradiculoneuritis. It's quite rare in the neonatal age group. And on spinal fluid, remember the albumino-cytologic dissociation and its association with Campylobacter jejuni. Okay, you made it.